Good evening, everyone. I hope you all are doing well and in good mental and physical health. On behalf of Alpha Phi Alpha's General President, Brother Dr. Willis Lonzo III, I am your brother, Jeffrey Sterling, MD, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. I've actually been a physician long enough that Brother Bailey, who will be coming on in a little bit, probably should write a book on the history of psychiatry and psychosis. There's a point in time in which certain types of things that we now accommodate used to be dealt with by a wide variety of psychiatric treatments, including electrical shock therapy and lobotomies and straitjackets and institutionalization, which actually begs the question, what exactly is psychosis? Is it really a set of um, societal constructs through which aberrance is defined as mentally abnormal? Or to what extent is it actually um, a physiologic condition of mental impairment and altered reality testing? We're actually going to be having this conversation both with Brother Bailey, who's our Deputy Surgeon General, to look at it from that historic lens, but we also are going to have a delightful group of just brilliant young minds who are going to talk about how the prism is viewed in the current generation, because the truth of the matter is that in today's world, in today's America, 20% of Americans carry a mental health diagnosis. So a pretty fascinating thing, to where we have shifted the pendulum to where we perhaps at one point in time internalized too much, resulting in neuroses, what used to be called neuroses and psychoses, to where now everything imposes so much stress that it has created all these mental health diagnoses. So today's conversation is going to be especially interesting, and I hope you enjoy it. Once again, allow me to introduce tonight's moderator, Alpha's Deputy Surgeon General for Mental Health. Brother Dr. Ron Kennedy Bailey is the Kathleen and John Bricker Chair, Professor and Head of the Department of Psychiatry at LSU Health Sciences Center. He is also the Chairman of the Board of Trustees of the Cobb Research Institute, and famously is the past President of the National Medical Association. We're always proud to have him here and proud to have him as Alpha's Deputy Surgeon General for Mental Health. Welcome, Brother Dr. Bailey. Have a great show. I'll be listening, and I'm looking forward to this great panel you've assembled.
Well, thanks very much, my good brother, Jeff Sterling. Very happy to join tonight. Very pleased to have been asked by yourself to serve his role as Deputy Surgeon General for this wonderful program, Alpha Alpha's Surgeon General Initiative. As always, as you, I also thank our General President, Willis Lonzo III, PhD, who I think conceptualized an idea that has merit and moment. The reality is it is important for us in healthcare to get the word out, to get the message out of who we are, what we do. Some would argue it's even more important in the African American community to do so because of a long history, I think, unfortunately, of misinformation and inappropriate access, lack of appropriate engagement when it comes to care, which has unfortunately led to a lot of healthcare disparities. Spent a lot of time on that early throughout my career. So I'm of the belief that shows like this, podcasts like this, have a great value. I think that education is power in the era of health and health understanding and health literacy, health education, we call it. And I, too, share in your comment. I think we have three simply outstanding, simply brilliant young minds, young African men. All three persons I've actually engaged in some individual work with. So I know these people individually and directly, all people that I'm proud to say I could see myself going to them as their patient one day because of the level, I think, of passion and compassion that they show in their everyday work, but also I think the level, I think, of energy they're going to devote toward their learning and understanding and moving forward in a healthcare career. I'm going to give very brief intros of all three, then let each one of them kind of speak on their own about their past background. I want the long version tonight. People want to know who you are. I'll begin with Alpha Brother Antonio Ibokiti, who's a fourth-year medical student now in Dallas, Texas. I met this young brother when the Student National Medical Association was actually here in town in New Orleans. He's the chairman of the SMA board, a role that Jeff Sterling mentioned he had some years ago. But in more in depth, he invited me to a program that he started, a barbershop program to educate and inform young men in our community about many of the issues regarding healthcare in general and mental health care. But as I participated in a 4-hour program that day, Jeff, When I got up, I just recognized that whether it was about healthcare or not, those young men that day in that barbershop understood that this guy cared about them and cared about their well-being. That goes a long way towards the start of the process of being somebody's doctor. Good brother, soon to be Dr. Ebokidi. Welcome.
Hey, thank you so much, Dr. Bailey and Dr. Sterling. It's an honor and privilege to be here today to really speak about some of the things that we deal with as men of color, but also as Black communities that deal with, as we'll talk about, psychoses and some of the different structural and oppressional components that really limit us from being able to kind of reach our full potential from a mental health standpoint. So excited to be here today. And thank you all so much for having me.
Wonderful. My second introduction, I'm going to mention a young brother that we have had on before. This is Antonio's first time being on, but it won't be your last. Another young brother out of Houston, Texas, who I'm very, very proud to say just matched to go to medical school there in Galveston, which I was with Jeff is my alma mater. So very proud of him for both elements of value. But also I've done some work with a young brother, Hong Nguyen, a high quality guy, highly intelligent, very excellent, I think, in understanding and deducing elements of a problem that one attacks. I think in what I do in what's called forensic work, I think that those are attributes that are going to serve you very well going forward as a physician. This young brother is trying to decide to go in aerospace medicine, but I tell you, Jeff, I'm still going to try to get him to go into psychiatry. We'll see. But good brother, Hong Nguyen, welcome, and I'd like you to introduce yourself.
Absolutely. Thank you so much, brother Dr. Bailey. Thank you so much for inviting me to come back on to the show. Again, Hong Nguyen, I'm very excited to say to everyone now, I know in the previous podcast, I was saying we're trying to get into medical school, and now I can confirmly say I will be matriculating to the University of Texas Medical Branch in Galveston in July. And so quick turnaround. I'm very excited. Dr. Bailey, I know you're trying to push me in psychiatry. Aerospace has a special place in my heart, but there is a way to combine the two. And so we're definitely looking at that. Other than that, I'm really excited to talk about our discussion today regarding psychosis and how it affects our communities and ways that we can combat them. So glad to be here.
Excellent. And I will take the opportunity to introduce a good alpha brother here in the great city of New Orleans, Louisiana, Gabriel Igbuna. Gabriel actually met through Hong Nguyen. Gabriel's a third-year medical student at Tulane University here in New Orleans, going to finish and go into the whole fourth-year process. I do want you to talk a little bit today as well, Gabriel, about that whole process. Applying, interviewing, it can be a monster for many. Another issue that I think we want our audience to kind of hear about. So we have a lot of issues to address tonight, but let me give you the floor and let you introduce yourself.
Hear me? Can you guys hear me?
Yes.
Perfect. Okay. So yeah, once again, my name is Gabriel Igbuna. I'm a third-year medical student at Tulane. Thank you for having me, Dr. Bailey, Dr. Sterling. It's a pleasure to talk about the things that we hold dear to us, such as mental health in communities of color. And I'm looking forward to having a great discussion about it all.
Well, that being said, long introductions, the like. I'm just proud of you guys and what have you. But let's get into it, as they say. We're talking about the psychiatric term psychosis. I finished med school in Galveston. I mentioned a lot today with Hong Nguyen on, but in June of 1990. So I've been at this business 34 years. And we have all kinds of terms we'll talk about tonight. But I absolutely want the audience to be aware that I know that all too often lay people, those who don't do what we do every day, calls this being crazy. Some psychiatrists struggle with the term for a variety of reasons. I never have. To me, the whole issue of being a psychiatrist, being a doctor, is understanding what problem individuals come to me with and trying to find a solution that helps them. I really try to reduce it to that level of engagement. So if a person uses a term that they're comfortable with to describe themselves or their relative or their cousin or neighbor, I want to hear that term because I want to hear everything they have to say to me about what matters to them and what's wrong in the life of the person who they're bringing in for care. With that being said, we call this psychosis. What is it? And we're going to jump right off the bat and go to the senior member of this threesome, the guy who's a fourth-year med student now who will be in residency here in 90 days. His name is Dr. Antonio Ebokidi. Dr. Ebokidi, let's talk a little bit about psychosis and what is it?
Yeah, absolutely. Thank you so much. So psychosis is really one of those terms that often what you talked about, Dr. Bailey, a lot of our family members, we kind of label it as crazy because we don't really understand why somebody's acting the way that they're doing. From the plain definition standpoint, is really kind of like the thought and the emotions that are kind of dysregulated or unregulated, and they lose track with external reality. And so what that means is whatever you're thinking, it doesn't necessarily match with what's going on with reality. And whatever emotions that you're feeling, it doesn't necessarily match with reality. And so a lot of the times when we think about folks who are dealing with psychoses, we try to identify exactly what are they thinking, right? Are they recognizing where they are in terms of space and time? Do they recognize what they're doing, why they're doing it, and so forth? And so when you can kind of think about if they are in tune with reality, if they're in tune with their emotions, you can kind of figure out at its core what psychosis is. And when we think about psychosis a lot, as it pertains to kind of Black community as well, oftentimes there's a lot of different first encounters that we have as a Black community when we come in contact with mental health professionals. Many of that will be in kind of those crisis intervention centers, right? So we think about the psychiatric ED, like here in Dallas, we have Parkland, and Parkland has a psychiatric emergency department. Oftentimes, folks of color, that's the first time that they're ever assessed for psychosis, right? Or some type of mental health crises. And a lot of that is also perpetuated from the fact that we kind of have our first interactions with police officers and law enforcement who don't really know how to assess whether or not somebody's in tune with reality from a thought perspective or from an emotional perspective. And so a lot of times you'll see a lot of us actually as Black folk, about 17.5% of us being diagnosed with some type of psychosis, right? And a lot of it being kind of overdiagnosis because of the perceived threat, aggression, and so forth. And so there's a lot of nuances and there's a lot of complex kind of interactions with psychoses. And I think knowing the definition helps us be able to identify it better.
Well said. I think that the issue about there being a lot of presentations, a lot of connotations is timely. I think that's one reason why it's confusing to some. And I hope the points that you've made resonate, why it's so important to try to get a fairly accurate understanding of what that person, that family member is actually reporting to us to try to move forward. Communication is a key issue from the very beginning in delving into this area. Dr. Egbuna, I'd love to come to you and hear your thoughts on what is psychosis, what does it mean, what have been some of your experiences, both professionally but also personally, in dealing with people in our community as it pertains to this issue.
Yeah, excuse me. I think we've done a great job on just explaining what the term psychosis is. And just in general, when an individual may hear or see things or believe things that aren't necessarily real or perceived by others as well. I'm currently at a University Medical Center here in New Orleans working on the behavioral health unit. So working in acute psychosis. And today we have a wide variety of patients, many of them African Americans, some who've had their first break in psychosis. And even as recent today, I had a patient who stated that, that they've been hearing voices for a long period of time, but that they didn't want to tell anyone because they didn't want to be feared as crazy or as other. And, I think part of it is being able to start destigmatizing these things, giving individuals the help that they may need at an earlier process. So the first time that they're having these assessments isn't in an inpatient facility.
You mentioned hearing voices. I want you to talk a little bit about that. What does that mean for our audience?
So what I try to explain is imagine you're hearing thoughts, because we all have most individuals have an internal monologue. We ask ourselves, is this right or wrong, or should I buy this loaf of bread versus that? But when I ask individuals if they're hearing voices, I often ask, are you hearing voices that aren't your own? And many describe it as hearing another voice or someone telling them to do things that are incongruent with what they want to do or how they feel. And so you can only imagine having this voice or hearing things or seeing things that you're just like, I can't get this out of my head, or I can't sleep this away, or I can't do anything. So that's why you're seeing a lot of individuals, try to self-medicate themselves, whether it may be by using drugs or other means that they don't know how, because they haven't been given the resources or the language to know about this term called psychosis that many are dealing with.
But trying to point out, I always share with families and patients, and we'll share our audience tonight, We spent a lot of time discussing what is hearing voices and the like. One data point I'll try to share a lot throughout tonight, as well as Gabriel can as well. But I think the audience should be aware that in our business, probably the signature diagnosis, the biggest and most impactful one adversely for a person's functionality when their brain isn't really working correctly is called schizophrenia. Probably the three in that category are the most impairing. We call those SPMI, or serious and persistent mental illness, or diagnoses of schizophrenia, affective disorder, and bipolar disorder, often with psychotic features. Those are the biggies, the real bad ones. About 80% of the time, 4 out of 5 individuals who have schizophrenia as a diagnosis will describe this hearing voices phenomenon that I thought was described and defined very well by Dr. Egbona. So thank you very, very much. Let's move to Dr. Soon-to-be student Dr. Hong Nguyen. I'm going to make that mistake a few times tonight, but that's all good. And I want to hear your thoughts. The title, Psychosis, what is it? What does it mean to people in our communities? What have been some of your thoughts? I mean, you're a great person to ask this question to because you haven't gotten to med school just yet. So in 3 months or whatever, it'll be your 4 months, it'll be kind of your first bite at the apple. I assure you, early on, regardless of what service you're on, you'll see someone with psychosis.
Absolutely. I think it's interesting from my perspective to consider psychosis because we actually have family members that attended Boys Home, actually Walter Burton out in New Orleans, who attended them when they were much younger. And, you know, reasons why they ended up there was because of some type of mental illness that they just weren't really aware of, or at least family wasn't aware of. And we would just kind of disregard it and say, oh, this is a local boy, and local meaning crazy. He's just spazzing all the time. And so we just didn't have a good understanding of what that is. It's just like, all right, he'll figure it out. And then as you get older, you start to see more and understand more things. It's like you're trying to tell somebody, hey, just figure it out. It's no different than someone having a heart attack saying, hey, just pump your blood regularly and like, get over it. And so that kind of transition has now been a pivotal part because we have to kind of explain to family now of, hey, there's something else going on that we actually need to address or find resources to or get help. And some family members may still have struggle with that or accepting that. And so it's a dialogue that continually has to happen, and it's coming around. And so for me, being exposed to that, it was like, okay, psychosis back then growing up was just like, all right, you're abnormal and we need help here. And now it's coming to a full circle moment of like, all right, the work that I'm privileged to do, Dr. Bailey, with you is look at all these different symptoms and the DSM-5 criteria books that we utilize. They actually did a study that I just so happened to find on Twitter that a lot of the symptoms for all these different psychiatric disorders all have these overlap with each other. And so when we talk about psychosis now, to me, I see it as a very broad term of a wide spectrum of all these different symptoms that lead up to overlapping areas that we then clinically dissociate with different disorders. And so as someone that is not in medical school yet, coming with that experience and then walking into it, it just kind of gives me a greater spectrum to look at things of where are we at in terms of seeing someone that may not be considered quote unquote normal or acting normal. And then from that perspective is, all right, how far off from reality can we then look at it and be like, okay, this, whether it be schizophrenia or any other type of symptoms that we're diagnosing as psychosis. And so I'm coming into it like that. I'm again, as I'm hearing both brothers that shared their perspectives on it, I'm also gaining a more richer perspective since y'all have gone through and maybe seen a lot more patients than I have yet to see. And so I'm grateful for that.
Well, let me just say, I give Sterling credit for saying we should get young guys on the show. He's been telling me that for some time, and he's 100% right because you guys are on mark and on target about a lot of issues. And I have a few things circled. I want to come back to the term spazzing with student Dr. Nguyen. But I was first to just share with the audience. So when we talk about symptoms, probably the big 5 to think about. If you have, as Hong Nguyen just said, some folks already know somebody, a family member, a friend, whomever, a neighbor. Hard to have lived this life for some time and not know anyone who we may have having a hard time kind of figuring out. So talk about hearing voices, these so-called auditory hallucinations, which are probably the most common. We also have what we call delusions, these fixed and inflexible, but kind of false and inaccurate beliefs. Like if I thought I was Michael Jordan or, Michael Irvin or somebody, if you will. And there's also what's called paranoia, which probably is the one that's most likely to occur when everything looks kind of normal to everybody else. You can dress correctly and take a bath and comb your hair and what have you, but really have thoughts that are remarkably illogical and aberrant between years. When we can see people having trouble, very often is when they're disorganized and they're wearing 3 coats in the summertime and they're doing things way out of whack. The ADLs are bad and how they take care of their hygiene and grooming and just their behaviors, and they draw attention to themselves negatively. They kind of have to be pushed away. And then a real big one we call catatonia. When you're so impaired, you probably have to be hospitalized. So those are kind of the big 5: hallucinations, delusions, paranoia, being disorganized, and kind of catatonia. And I think, as Dr. Buddha pointed out, there could be kind of a spectrum along a full process. It doesn't start off with the worst issue. It starts very slowly. And that kind of gets me to the issue that I'm going to come to Dr. Tony Ebokiti, and this issue of fear. Because I think one of the struggles in general in my business, especially I think in our community, is because people are afraid other people, lay people, family and friends. We mistreat individuals with a brain illness. We are violent toward them. We're antagonistic toward them. They don't get the help that they really could get very often. And that's an issue that I think our community needs to own up to. And we should do better. I'm interested in hearing your thoughts, Tony.
Yeah, absolutely. Like I was saying, there's a lot of structural kind of entities that really play a role in psychosis. A big feature most of the time when psychosis is first seen, it's first seen in the psychiatric ED. And it's usually probably at its worst at that point, right? Because at that moment, it's become a crisis. And so it never really was able to be treated early on, right? One of the brothers said, oftentimes it's something just like in any other illness that we just really never get treated for because of perhaps the stigma in our own homes, right? Like a lot of the times in communities of color, we often say, hey, let's just pray about it. Like, you're okay. Let's not bring our issues and share them with anybody else. And then oftentimes that often perpetuates with just like the structural society with the fact that, racism does increase mortality and morbidity of this particular disease. And so when we kind of think about kind of how race plays a role, there lies the fear, right? The fear lies with how I'm going to be treated, whether or not I'm being treated like I'm crazy by my family, or whether or not I'm treated like I'm aggressive, or that I'm a problem, or that I'm a danger to myself or others by society. And so I think, those particular entities really do play a huge role on not even just how the disease presents itself, but how quickly somebody who's suffering from psychosis, schizophrenia, or anything like that can actually receive help.
In that space, Tony, what are your thoughts about race and its overplay in this setting? I think you make a timely and, in my estimation, an accurate point, and one that I share, that it definitely plays a role and at times can make the situation worse. I've often thought maybe that's in part because in some ethnic groups, out of fear or other aspects of stigma, which you mentioned earlier, we don't go for care at all. One also does wonder, though, if there's some components of being psychotic, which always has an element of truth to it. There's always a little bit of truth when somebody's thinking about some things that don't make a whole lot of sense, but it's not fully, I'm from Mars and things of that nature. There's a piece of it that's truthful. That's one reason why very often people kind of hang on to it so much. I think that's one reason it's so tough to get care to individuals often when they need it. But the issue about how race plays a role is of interest to me. I'm interested in your thoughts, Tony.
Yeah, so I think the racism piece kind of is also embedded in a couple of other things like stereotypes as well, and microaggressions as well. I remember the first time I had one of my patients in the VA, and seeing him, he had like a laundry list of different diagnoses in his chart. I'm talking about like mania, schizoaffective, schizophrenia, like all of these particular diagnoses. And so oftentimes when I see all these different diagnoses, I just want to kind of break it down and see, like, is this actually true? Should you actually be labeled with these diagnoses? Because as we know, once somebody sees these diagnoses in your chart, they're going to treat you a certain type of way. They're going to have a certain type of perception about you. And so just talking to him, he talked often about how Many of the folks, he came in, he was just feeling very depressed at that point in time. And so he took a lot of meth, and he was very much just kind of amped up, I would say, right? And so after that, he was just kind of getting a laundry list of diagnoses, but in reality, he just had a substance-induced psychosis, or he was just pretty much psychotic because of the substances. However, for whatever reason, he had all these diagnoses that are going to follow him in life, right? Diagnoses that have no bearing on the fact that he's a substance. And a lot of that is based off of people's perceived notions of us as Black people, of us as Black men, to be aggressors or to have certain types of thinking and rationale about things that don't necessarily align with, who we are. Or more so, they're just there's a divide between what they understand to be our culture and what they understand to be something that they feel threatening. And so oftentimes you'll see that a lot, right? We'll see that a lot in the VA. We'll see that a lot in just the county hospitals, where folks have all these different diagnoses because they were too aggressive, because they were trying to get more clarification on something, or they were too flat affect, or they seem restrictive, or they just seem unengaged. And a lot of this time, this is something else that they're dealing with, either substance abuse, depression, anxiety, some other mental illness that is being misconstrued with psychosis, schizophrenia. And unfortunately, they get labeled for the rest of their life.
Timely points. I want to come back to Hong Nguyen about spazzing, and then next we'll go to Gabriel and talk about medical comorbidities, because I think Gabriel, Tony just pointed out, and if you're on inpatient unit at UMC right now, I'm sure you're seeing people, Gabriel, with both medical and psychiatric problems, and combined, that things are worse. But before we get to the medical comorbidity piece for Gabriel, I want to go to Hong Nguyen. Use the term spazzing. And one note I made to myself tonight to ask questions to you guys was all these different terms that families use. I throw the word crazy out, not to be disrespectful, but that's kind of a common one. But there are many terms, and I wonder if people make these terms up because they're so uncomfortable with the process and what the elements of the illness that their family members have. So spazzing may be one, but the overarching issue of the terms is what I'm concerned about.
Yeah, I think it's a way for us to describe yet not understand what we're witnessing. I think that's one way that we use these terms. And I think the other aspect too, if we end up searching up what this is and actually saying this is a psychotic symptom, just even saying the word psychotic in some of our communities, it's just like that's a big no-no. Or you now have to open this can of worms, and so it's easier. At least when I was growing up, like we use spazzing or tweaking. It's like, all right, he'll be fine, but there's something there. We didn't have to fully address or take accountability that maybe this person needs help, and we need to be the ones to do it. And so there's that aspect that I've seen. But I find it's interesting now that the current generation, or I say younger generation, is a lot more empathetic to what these are. And I speak on this from a standpoint of having the privilege of teaching high school students of the current day. And what they were telling me was the conversations that we're having here are conversations that they're openly having, and it may be due to them having access to just the internet in the palm of their hands. But they're openly saying, yeah, like I go see a therapist, or I go see a psychiatrist, and they're 15, 16, 17 years old. Or they are known, oh, I have to go take my medications. I'll be right back. I have to go to the nursing station. And they won't, it's not something that they hide anymore or push aside. So I think there's times where those words that we use, like spazzing, it's now, at least from what I've seen with the younger generation, they don't even use it that way. They actually say what it is, which is being more upfront and deliberate, which is nice to see as it's empathetic, but I know that's not always the case.
Well, I'm glad you said that. You actually said it better than me, but that was what I was trying to get at. The fact that the terms may change, may be generational. And I'm sure one of us, Dr. Sterling, want us to have this discussion tonight. All you guys are young. I'm not so sure how old Sterling is, but, I may be 35 or the like. We all the same age in this business. I'm sure Sterling are 30 years older than all you guys. As they say, we got shoes older than you guys, if you will. But it's important for all of us to know what the terms mean. And I love Hong Nguyen's point. If the terms are changing in a way that's more empathic and potentially more understanding, it could be that our society is going to be more compassionate and not less compassionate than it was in an earlier day. Certainly when I was growing up in the 70s and 80s in Beaumont, Texas, when I was in med school and residency in the 90s in the Houston area. My experience has been very different. I mean, I went to college in Atlanta. I was at college 82 to 86. And I'm embarrassed to say it, but people would laugh and joke about bringing physical harm to individuals who had brain illness. It was just really a bad day in a bad way, and something that a lot of young men, I thought, did incorrectly and inappropriately. So I'm happy to hear those comments in that regard. I'm going to shift a little bit now to Dr. Boone. I think that you sprung a thought in my mind, because the one thing I did on notes to ask today about you three was medical comorbidities. I have 10 things I'm going to get in this hour we have today. Clearly, our patients are more ill, not less ill medically, if you have a brain illness than in other areas. Like I've read throughout my career that really only rheumatoid arthritis of the 7 most common medically diagnosed illnesses in the U.S. occurs less common in persons with brain illness than all the others. So our patients have more heart disease and more cancer and more stroke and more diabetes and the like. If you're on inpatient unit right now, you really are the best person to talk to us now about what's happening on inpatient units, how are African American patients being treated, and that is my hospital, I'll say for the record. Are these stigma issues more likely to make individuals who have psychotic illness not get care? I'm really interested in what your experience has been. I mean, you're right in the trenches, man.
Yeah, I think we're bringing about some great points. First and foremost, as individuals of color, you're not often given the benefit of the doubt. So let's say a first responder or a police officer is responding to an incident. You're not giving the indication like, hey, this person may be going through something. It's this person who is seen as a threat. So your first thought is this person is resistant. This person is going through all of these other things, not that this person may be going through a state of psychosis. So in that instance where we're talking about the first encounter is that of like potential violence, and not giving the state that, hey, this person isn't in the right frame of mind. I think that that's just the precedence and the tone of how they'll respond they themselves, and also how those who are taking care of them will also respond. And I think we bring a great point on just the medical comorbidities. One of the most important things is that, like, if we talk about the state of something as depression, right? If you're having someone who's depressed, you're less likely to do the things that you're normally doing. Like, you're less likely to enjoy the shows that you do. You're not getting adequate sleep. You're not eating. And therefore, let's say you have anxiety or you're having diabetes. All of these things are going to be getting worse because you're not being able to take care of the depression itself. So these things are often going hand in hand. And what we're seeing is that with the rising rates of depression and suicide, especially after COVID, these are the things that we should be concerned about. These are the conversations that we should be having. And I think Brother Wynn brings a great point about just the stigma that's being removed. I think the conversations are changing, and I'm very hopeful of the direction that we're heading in the future. One of the things that I find is that we're now having this conversation so much earlier, whereas before, these are things we used to keep in, quote unquote, in-house or in the family, in hush hush. And the concern about that is we've allowed society or, TV or pop culture to tell us what these things are. And I think the detriment behind that is that our educational or learning points are things that are inaccurate. So for example, most often when people think about bipolar disorder, they think about Dr. Jekyll and Hyde, like somebody who's just hot and cold. I'm thinking about somebody who has just been unable to go to sleep for a few days, so their brain isn't processing at the normal capacity or normal speed. Or something as, turning on the news, and unfortunately how we're living in a society that's constantly prevalent with gun violence. And whenever there's a school shooter, the first thing you hear about is like, okay, they're somebody with a mental illness. So now we as a society are afraid, and we're constantly thinking like, hey, if somebody has a mental illness, I need to be afraid of them. And these are the things or the challenges that we're facing that are in our way. And hopefully as we're starting to remove the stigma, we're starting to get better language, and we're having these conversations, understanding when the onset of these things are, hopefully we can make a better impact on how we're treating people and how we treat each other in this.
To this point, I clearly think that the issue of how we treat people matters. I've often thought that the disdain for humanity comes out often in a couple groups that I'm very sensitive to, African Americans and the mentally ill. And so much of what happens, I think, in work. And when all issues are in play, At times, I think we see the worst of people, and we should do better. And I don't only mean somebody who will pull out fisticuffs and punch somebody. I mean, I'm old enough to say, I think I'll keep my job when I say it, but the government has, throughout the entirety of my career, underfunded payment strategies for individuals with a brain illness disproportionately, and I think based on bias, versus if you have a healthcare problem of the heart or lung or the kidney, even when the data would argue that many of our ailments are more adversely impactful, more likely if we treat them to get somebody back to work and independent living, and also a lot more likely to be manageable within a reasonable circumstance of care. So all of the metrics of how you normally decide what you're going to invest in a value-added property, a business, for example, are on the side of investing in mental illness, and we've not done that very well throughout the entirety of my now 34-year career. So I think you're timely you come with that, Boone. I think the reality is it is an issue of humanity, and I think in these educational programs that we're having tonight, one thing that has to happen is that people who hear our message has to be that we first and foremost have to treat people with brain illness as human beings, and we treat person thinking these other type settings. I roll back to Brother Hong Nguyen, because you really did catch my attention with several things you stated, and I want to come back to the younger people than the three of you who you're taking care of, who you provide care for. And now that you mentioned language and terminology that is a bit more compassionate and impactful, compassionate and empathic, I apologize, and why they probably don't use a lot of the negative stigma, calling people by these adverse terms. I also wonder if individuals recognize the vulnerability of others when things in the brain don't work right, or as well as they actually should. Because when you recognize people's vulnerability early on, you're less likely to engage in the adverse actions toward them. Gabriel, when we think about it, when you use the term, talked about gun violence, one does wonder kind of what are younger people in high school and the like saying in that regard? And do you think that they're taking advantage of that vulnerability or somehow understanding it better than we did in the past?
Dr. Bailey, I believe that unfortunate reality is that morality is still a spectrum that's vast, and there are going to be individuals that will take advantage of understanding or knowing or seeing that an individual may be vulnerable to the fact that they are openly having these discussions or disclosing information about how they are or how their brain operates, and that's going to be an issue. The seeking of humanity that we were just talking about, I think, is an area where we kind of have to play in. But one thing I'm noticing as well is that because of access and just the access of things, we're desensitized, but we're also, I guess I would just say we're desensitized to a lot of different things to where we just don't care. We're very apathetic about things that are occurring. And so you really have to put yourself in a position in these conversations to really dive in and create that safe space so that fear is not being interjected, whether it be for oneself, but also how we plan to treat others when we realize that someone may have a psychosis or a mental illness. And so these discussions, while they're happening more frequently, it can't just be, we oftentimes focus on health literacy being that if you know more, you'll do better, which is one aspect of it. But I think the other side of that is understanding that there has to be an active practice to not abuse that knowledge that you have once you gain it, and that what leads to some of the conversations that are already happening. Like bullying still happens in schools based on whether or not someone has a mental illness, or we see an episode of that. I think you will have more support of those that will advocate for that, though. And so, but you're still going to have it there, and that's still present in the schools today.
Tony, your thoughts in this space? This issue of vulnerability really kind of comes to mind.
Yeah, so it really makes me think early on from what James Baldwin said in one of his literatures. He said, education is a priority. How can we resist exploitation when we don't even have the tools to understand it? And oftentimes I really truly believe that often many of our patients don't have that knowledge, which is that empowering components, which really allows them to, have a little bit more autonomy, have a little more charge and just like control over their lives. just knowing the different things that they're dealing with and how they can actually advocate for themselves. Oftentimes too, we kind of see it in our youth as well. Kind of having that knowledge really does provide a little bit of that bridge, I think, for that empathy, right? Oftentimes we kind of judge and we hate on things that we don't understand. And so I think when we have an understanding of, I have a classmate and he's having delusions, thinking that he's getting voices from God, or he's getting voices from the devil. And he's also, coming in and he's having disorganized thoughts, and he's dirty and his clothes are dirty and he can't really kind of pay attention. Maybe now I can kind of look at my classmate more as like he's struggling. How can I help him? Because I know that he's dealing with schizophrenia versus, oh, that's the same kid, like Brother Wynn was saying, that's probably spazzing out. And so I think that knowledge piece really does provide us an agent of change to really be able to champion, not just for ourselves, but the folks next to us as well.
I'll turn tables a little bit. We're going to come to you, good brother Gabriel Boone. Talk to all three of you now a little bit more about yourselves and how you kind of handle the stressors of day-to-day, not only life, but these high intensity lives of being African-American men who live in a violent society. I have to kind of admit that. I'm with my son a lot more these days, and he's in his 20s. And when I'm with him, I'm just thinking about what it would be like if I wasn't in the car with him, if he's driving, if a cop stops him, all that kind of stuff goes through your head. But the other issue is that although psychosis is kind of the big ticket item on the end of the spectrum of illness, these issues often start with anxiety, entry level, and they can grow to clinical depression and the like. And they can actually grow to paranoia, hallucinations, other forms of psychotic illness. What probably differentiates some people who have very stressful lives than others are compensatory strategies that blunt them from it going too far and manage it. And we all know the story of the person who couldn't block it and it went too far and they got very, very ill, very, very sick. And the families and friends are saying, what happened? And he was normal before and the whole life it will. So we all can be on that continuum. So actions and behaviors that modify or decrease highest level stress, which I would argue may be worse if individuals in a society where you may be the victim of discriminatory bias or racism or all the isms of society that can be adverse toward you, can be key. So a chance for you to discuss as individuals, what do you do to kind of maintain and limit these difficulties from happening in your own lives?
Yeah, I think that's an amazing question. For me in particular, I've learned that I have to find a way to separate work and also personal life. So for me, when I come home and after I eat or something like that, I'll do a 10-minute meditation. And for me, it allows to create that separation. Like, hey, now I'm home and I can leave work at work. I can now transition into being at home, being at peace, or now doing something else. And I think one of the things we have to start discussing is that we were never really given the resources or the tools to navigate a lot of the things that we're encountering in this life. Whether that's, disappointments, rejection, failures. A lot of times when we're younger, we're told like, oh, just pick yourself up or it's okay. But nobody ever gave us an actual outlet or actual information or tools like, hey, if this happens, why don't you try this? If you get this, if you encounter a situation where you feel like you're at your lowest of lows, who are your tiers of support? Whether it could be a parent or it could be a friend, and then so forth and so forth. An actual chain of command of like knowing who to go to when these situations happen. I think that if we're able to do that, it starts to equip us with the ability to understand like, hey, not only am I going through something, but when I'm going through something, I have people who have my best care in mind. And just being an African American male in this industry, I think it's telling to know that our patients, one, feel a connection with me because they don't feel like they're heard anywhere else. And it's unfortunate that it sounds as if we speak a different language. And I find that more concerning because as we mentioned earlier, some of these diagnoses follow for the rest of your lives. So if you're talking to a certain physician who's not understanding you, let's say they give you a diagnosis of something like, borderline personality disorder. In the near future or distant future, everyone who's going to be looking at your chart is going to see this one thing, and now they're going to automatically assume things about you, and they're going to treat you differently based on this without even encountering who you are. So I think there are some concerns, but I think what we're doing now, and even having these conversations, and now being able to start having the ability to talk to each other, talk to our younger generation about things that they can do to, help soothe themselves that aren't drugs or aren't other risky behaviors before they encounter stresses of life on their own, such as college disappointments or real other life stressors.
No, timely, and finding ways to intervene early, I think really matters. Hong Wen, any thoughts?
Yeah, I was reflecting back, and I was mentioning this before at one point. It was as I reflect back throughout my timeline of certain points in my life, uh, it's kind of like a spontaneous, why am I feeling like this? And then because I didn't know what anxiety or symptoms of depression were, besides what you would, I guess, see on TV or what's just passed around in conversation. But the first time I actually could acknowledge that I had anxiety or was experiencing anxiety was like a whole lens was peeled behind my eyes, because everything prior to me acknowledging that I'm feeling some type of way that is uneasy and I don't know what it is, everything before that is kind of just like a blur, because I was either finding things that would comfort me, like food. So Popeyes is a comfort food for me, and we ate that growing up all the time. So I find myself eating Popeyes, and or alcohol and going out with friends, and risky behavior. So it's like, up to this point of like I've noticed, oh, I'm feeling some type of way, which I can now say I experienced anxiety at this one point. There was just so many other avenues I could channel that energy and not feel it. And so now, as I become more aware of, I guess, myself and a better understanding, my outlet for really dealing with life stressors or any type of negative emotions I may be feeling or struggling with, I found that outlet really through the sport of triathlon. And so that to me is the one thing that I've learned that keeps me grounded the most, is how do I stay present in the moment of right now? And how do I prolong that as long as possible? And so when you're swimming, biking, and running out there, like I'm focusing on one stroke or one pedal or one step, and I try to go as long as I can. And so that keeps me in the present moment regardless. And it's now just become very, very much so a therapeutic outlet for me. But those are kind of the things that I do. And if that doesn't work, or if I find myself starting to crave a Popeyes or Taco Bell or something, that tells me, all right, something is misaligned, and I would have to sit down, because I tend to like to avoid as well. Like I'd rather just push it to the side and just keep trucking along, which I've learned does not help either. And so sometimes just addressing things or going towards the things that we often avoid is one of the ways that we can decrease whatever we're experiencing, because ultimately what comes on the other side of that is the empowerment that we're all looking for to keep pushing forward and taking those steps.
I'm going to Tony next, but I'll just share with you how healthy and proactive a comment that really is. We're trained in psychiatry and psychotherapy to ask someone pragmatically, what do you do when you're stressed? And we're trained to listen to figure out whether or not they give us an actionable activity. I go to Popeyes, versus if they very quickly return right back to the discussion of the emotional issues that cause them to be stressed in the first place. One value added of therapy is being able to get to that point where a person can understand and acknowledge and identify what action to engage in. A classic one, you can go to Popeyes. Most commonly is they go to the bar and get a beer. And then because they go to the beer, other things happen, and then you get, esophageal varices, and then you wreck your car, DWI, and all that kind of other stuff, whatever. But many people just cannot say, when I'm stressed, go get a beer. They still blame it on somebody else, and they got a problem with this spouse and this conflict, this relationship, and all those kind of things or whatever. So I just simply say that that's timely, and I think very psychologically healthy. So now we're going to go to the home run hitter, the cleanup hitter, they call it. The guy who's a fourth-year med student who's done his psychiatry rotation. Tony, you're on the deck.
Yeah, of course. I think it's a variety of things. One, like things that we can kind of do, small things, and then large things. What are we doing that is kind of structurally changing kind of the dynamic in our behaviors going forward? And so for me, I've noticed that things that really kind of when I'm kind of going down to a hole is I'm binging like TikTok, I'm on social media. It's just kind of like this proverbial, like I'm feeling kind of, not feeling my best. So I'll isolate, I'll go to social medias and I'll just kind of let that thing run for a couple of hours. And so in its own right, like social media, sometimes too much of it is kind of bad for you, right? Because you're getting microdosed with so much negativity that unbeknownst to you, you're kind of feeling all of these different perpetual emotions that put you in that position in the first place, right? All the different negative stereotypes, the deaths, the just kind of the many changing things that's happening on social media, that's happening in the palm of your hand is very difficult to kind of really manage that, right? And so I think one of the things I always tell a lot of my patients is just take a step away from the social media. Use that as an opportunity to kind of go get some fresh air, go for a hike, go swimming. A lot of the things I like to do is lifting weights. And so I'll go to the gym and I'll lift weights, and that'll really allow a lot of those endorphins to go and flow and to really make me feel a little bit better and stronger. But one of the things I always say is who is giving therapy to the therapist, and a lot of us are being or trying to train to be the next generation of psychiatrists that we need in our communities, but we can't do that if we're not helping ourselves. And so therapy is so important. And I think right now, especially when you're kind of in that undergraduate stage, that graduate stage, where therapy is a little bit more accessible and amenable, and you can kind of create the habits and start to get utilized and used to using therapies, finding the best therapist for you, someone who understands you, figuring out what type of therapy works best for you, cognitive behavioral therapy, dialectical behavioral therapy, all these different particular therapies that you may need depending on who you are, what season you're in, and really helping you kind of shape those behaviors and figure out what are your triggers, what are your maladaptive coping skills, and how can you be a little bit better on the other side. And so I always preach therapy, man. Therapy. And even for your kids as well, therapy, because it's easier to build strong children than it is to fix broken men. And so we really need to be able to make sure that we're also fostering our youth, because that will be the next generation. And then maybe we'll start to figure out what is it like for us to destigmatize mental health. And so when we're kind of being combated with psychoses, or we're being combated with a system that doesn't really appreciate us, we'll have us to appreciate ourselves on its own.
Well, I share that timely. And one advantage that Tony has over Gabriel and Hong Nguyen is that I've seen him in action. I mentioned as you started today about the barbershop event. And I've been running this a long time, guy. I'll share with you. I thought, and that went on 4 hours. I thought your management of the emotions and the issues with a group of probably about 10 to 12 people, but they changed throughout a little bit, so some news came in or whatever. I thought was frankly masterful. And I thought really spoke to the gist, I think, of being culturally competent, using the terms and the language and making a connection with the human beings who were there. It's not right or wrong, but it can be different in a barbershop in New Orleans talking to a 24-year-old African male than if you're in a grocery store in Ames, Iowa, talking to a 75-year-old different ethnicity woman. But it's our job to get it right. And we're responsible for the ebb and flow of effective communication in that setting, but I think often doesn't happen in these issues regarding when people are psychosis. They're misunderstood, and the communication issues, I think, very often are aberrant or bad or kind of out of line. So we're going to do a few things. Normally at this point, I'd say we're going to go about 60 minutes of didactic and about 30 minutes for back and forth. So before I bring on my great friend, our Surgeon General Jeff Sturman, asked for him to give me a brother's prerogative. I'm doing something I've really not done before, but I think these bios are so outstanding. Jeff, want to read these guys' bios. I take full blame for not having them at the very beginning, but the technology is good. Hong Nguyen sent them out to me, so I'm going to read them to you, if you will, as I should have read at the very beginning. You guys can think briefly about your closing comments. I'll give you a minute to close after I read your bios, and then I'm going to bring on Surgeon General Jeff Sterling, and he very often sums this up in an outstanding way. First, Antonio Ignokiti. Antonio Ignokiti is a second-generation Nigerian American from Little Rock, Arkansas. Graduating from the University of Arkansas, he earned a Bachelor of Science in Biology and a Bachelor of Arts in African American Studies. Continued his academic journey, he completed the pre-medical post-bac program and a Master of Science in Bioethics at Creighton University in Nebraska. Currently, Antonio is a fourth-year med student and an MBA student at the Ann Burnett Marion School of Medicine and Anita School of Business at Texas Christian University. It's in Fort Worth. He recently matched, oops, I lost that 1 second. He recently matched into psychiatry general residency at UCLA Summer Institute for Neuroscience and is set to be the first doctor in his family in May. He'll finish in May of 24. Antonio served in the 2023-24 National Chairperson of the Board of Directors for the Student National Medical Association, the largest medical student-led nonprofit geared to supporting current and future minority medical students. In his position as the immediate past chairperson, he continues to consider it a privilege to serve the SNMA, emphasizing the profound impact it has had on him as a student, recognizing the importance of creating pathways for us in healthcare and lifting us up as we climb towards success. And again, I'd be remiss if I didn't take the opportunity to come into our group again. I met Jeff Sterling, the current Surgeon General of Alpha Alpha, when he was the chairman of the board of SNMA in 1990, about 34 years ago. He was excellent then, and he's excellent now. Great work, I think, in this area. I'll end by saying he was recognized by the U.S. Public Health Service, NIDA, the National Institute of Drug Abuse, and NMA, National Medical Association, and 100 Black Men, and the APA, American Psychiatric, receiving grants and awards for work in integration of therapy in the barbershops. This barbershop talk therapy project we mentioned earlier in historically marginalized communities. Antonio's career interests lie in the field of psychiatry, community psychiatry, addiction, and psychoanalysis. He became a member of Alpha Alpha fraternity, incorporated by way of Kappa Kappa chapter, University of Arkansas in fall of 2014. I normally at this point I'd say welcome and give you an introduction, but we've been going on for an hour, so let me just say I'm glad we had you, and I'm glad to make those comments. Let's go to my good friend, Brother Gabriel Egbuna, third-year med student at Tulane here in New Orleans. Gabriel Egbuna is a current MS3, third-year med student here at Tulane from Houston, Texas. Gabriel has an extensive experience in mindfulness, well-being, and community engagement. Before embarking on his journey as an MD candidate at Tulane, Gabriel spent 2 years as a high school advanced placement physics teacher at Yes Prep Public Schools. In this role, he served as a curriculum liaison for the physics department, enhancing the quality of education by ensuring students were presented with culturally relevant and current references for complex topics. Gabriel earned his bachelor's degree in psychology at Texas A&M University and his master's in biochemistry and molecular biology at Tulane University. Gabriel was initiated into Pi Omicron chapter of Alpha Alpha fraternity at Texas A&M in the spring of 2011. As well, met this young brother, outstanding work. I'd be happy to say that I was a speaker for Alpha Alpha for Founders Day about 4 months ago, and you always got to lean on a young brother who knows all of the recent history. So I will always thank Gabriel Egbuna for all the help he gave me. He made me look good that day, and I can see why. I think both you guys really outstanding comments. And next I'll mention Hong Nguyen. Good brother Hong Nguyen is a Health and Wellness Ministries program manager at the Fountain of Praise. Hong develops programs to educate the community and congregation to improve health outcomes, provide health awareness on disparities, and provide free medical screenings through partnerships with various health organizations. Hong is a diabetes self-management education and support instructor and Healing Circles facilitator for the National Alliance of the Mentally Ill, NAMI, in Greater Houston. Concurrently, Hong Nguyen is a professor at Houston Community College in the Department of Biology with published research in breast cancer regarding TP53 mutations. Before joining the Fountain of Praise, Hong spent 3 years as a high school AP physics teacher, also at Yes Prep Public Schools, as a long-distance triathlete, as I think we heard today. Finally, Hong earned his Master of Science in Biochemistry and Molecular Biology at Tulane University School of Medicine and Bachelor of Science in Kinesiology at the University of Houston. Hong was initiated into the Eta Mu chapter of Alpha Phi Alpha fraternity at the University of Houston in the spring of 2013 and is currently active in the Alpha Eta Lambda chapter in the Greater Houston area. I, again, want to honor all three of you guys. I think that your comments today are outstanding. I think that your work, I think, deserves acknowledgement at a high level. I think that all of you have CVs and initial comments that deserve note. I think Jeff Sterling, we're in good hands in Alpha Alpha with young future leaders like this. Jeff? I'm sorry, my bad. I was supposed to give you guys 1 minute at the end. I apologize. So each of you guys gets 1 minute at the end. I guess he gave me a chance to go back to that. So you all get 1 minute as your final comments, and then we'll go to Brother Jeff Sterling. Why don't we go to Gabriel first this time? Brother Egbuna?
Yeah, Dr. Bailey, I want to thank you and Dr. Sterling for having me, especially on topics that I hold near and dear to my heart when it comes to our communities. They say one of the highest things you can do is observe without needing to evaluate. And I think that that's something we can take forward in when it comes to issues of psychosis, is being able to observe but not needing to label as well. I think that that begins with us understanding things and having the knowledge, the language to do these things. And I'm excited for where we're headed. I think we're finally on the right path of being able to have these conversations and thus action behind them. I'm happy to be a part of that.
Excellent. Good brother Antonio.
Yeah, I'm just very grateful for you all to kind of open this space. This forum is just necessary for us to have these discussions. Oftentimes, we've talked about it. Before we can destigmatize something, we have to have the discussion, and we have to come together in unison in brothers' arms to be able to discuss, figure out solutions, and to really inspire the next generation. And so for any of those who are interested in the field of psychiatry, please reach out to myself at any capacity. And I feel like the rest of the brothers on the call are very much amenable with that as well. Goodwill is the monarch of this house. And so we just need to be able to continue to foster that. And then I think, we'll be able to make a substantial change as it pertains to our mental health. So just thank you all again.
As well. Good brother Hong Nguyen.
Thank you, brothers, for just having this amazing discussion about our topic today. It's good to hear the perspectives. It's good to hear, and actually for myself, learn. Always something new every time I get to be in a room with brothers that are well more knowledge than I am and share their experiences, which gives greater insight for me, but I'm sure for anyone else watching as well. So extremely grateful to be a part of it. We're making good strides. I'm very hopeful for the future in terms of how we deal with psychosis or any other mental illness. This Surgeon General health initiative is incredible. I tuned in last week and saw Brother Dallas Jones talk about menthol cigarettes and the banning of that, but also how that plays in part. And then just our discussion today, I was drawing connections. We said substance-induced psychosis, and how there's a lot of overlap in a lot of the discussions that we're having within the Surgeon General Health Initiative. And I think it's just extremely beneficial. And so my push is that we continue to do this great work. The reward for good work is more work, and that through that we can invoke the changes we want to see in our communities.
Well, I wouldn't close out. It does look like our Surgeon General is, I think that the time went past that he had to hop on a flight. He's a busy man, and he's going places. So my closing comments are along that line. I want to thank all of you for your time and your effort. I think Jeff is back. Are you up, Jeff?
Yeah, I never left. It's just a little bit loud. Let me know if you can't hear me.
You're good.
You know what? I love you guys, and just as brothers and as young professionals, I know that Ron said he and I had our time when we were together and became lifelong friends and colleagues. And I look at the three of you and see what the future can bring. I started this conversation with a question, and I love the way that you formulated an answer for me. And I hope that over your careers and the various capacities in which you engage psychology and psychiatry, if you choose that as your specialty, you remember that they are both societal components and brain-based organic components that contribute to what we define as mental disease. And that level of sensitivity that you guys have been expressing this evening really will serve you well professionally and serve the next generations of patients well. So I couldn't be more proud of you guys, and it's nothing but love for you guys. And as always, thanks to Brother Dr. Bailey for taking this on and doing it with such flair and aplomb. I would just point out that the next Surgeon General initiative will be occurring in 3 weeks, and we're going to have a multi-specialty approach to the topic of access to care and how that impacts healthcare disparities, social determinants of health, and offer challenges to overcome those considerations. It will be my alphaversary, and as a special treat to me, on my line there are 5 of us that became physicians, so the panel will include the 5 of us representing various healthcare specialties, so that'll be unique and fun. and informative as always. So as always, I thank you. And on behalf of our board of directors and brother General President Lanzer, I want to thank you all for attending this evening, and be safe, be well, be healthy. Good night.